So I'm an interventional pulmonologist. You may never have heard of that, and when I started practicing pulmonary medicine, it actually didn't exist. It's a field which has grown with changing technology. I'll go to the end line. One of the tools, the tool I use most commonly with lung cancer is called an endobronchial ultrasound scope. It's a scope which at the tip of it has a tiny ultrasound chip. So I have vision at the end of the scope, but I also can look through tissues, look through walls. With this scope, I can go down into the mediastinum of a patient who has or might have cancer. I can find the lymph nodes that cancer might have reached, and I can specifically sample even different areas of a lymph node. We did a case today. A guy had huge lymph nodes, and we went into different segments. Several passes were negative, and then we found a segment which actually had a lot of cancer cells in it. Cancers don't just homogeneously spread like a well-mixed ice cream. So I have this very, I have these kinds of tools which allow me to accurately go into the middle of the thorax and both diagnose and stage lung cancer. That is a tool which started being described in 2000, became available in 2005, and is a mainstay of my subspecialty now in 2010. So I'm part of a very rapidly advancing field where we've created a whole new sort of category of specialist. If I look at lung cancer over the past 20 years, including the time when I wasn't doing all of this micro stuff, I'd have some more global comments. One global comment is that our survivals, if we can't take it out, I'm the front door. I kind of diagnose it. He's the side exit. Mazen's the guy who treats the people we can't cure. I think we've done very little to improve outcomes, and he'll speak to that, I'm certain. And I think that's one of the big disappointments. I think one of the biggest advances is that we've started to learn different specific mechanisms, and one of the biggest disappointments is that hasn't translated into specific cures. But there's one other area that I think is important that we don't talk much about. In this age of specialization, patients have been taken apart into a series of body parts. So I've got the lung cancer, the stage 3A lung cancer next door, and, I'm going to talk to him about giving, carboplatin and another drug, some couplet. And I think this disintegration of the human being into a series of medical issues is one of the more destructive forces in American medicine. I would say that there is a new move, which is the palliative care move, which involves hospice, but not only hospice, which reintegrates the patient. And I'm sad to say that it takes a new subspecialty to take a patient and look at that person again as a whole and try to teach the whole patient as other specialists, like myself, like Dr. Safar, are working on this specific cancer. So I'm just trying to get an overview of what I thought was important. And I think that reintegration of the human being as not just a set of parts is a crucial part of the good things that are happening now. That's enough out of me.